Great. Well, hello, everyone, and welcome back to the 2024 Global Health Leaders Conference at Johns Hopkins. My name is Siam Rezwan. If you're watching a recording of this session and were unable to join us live, today is July 13th, and we are honored to be featuring Dr. Tom Quinn as our opening featured speaker of this year's program. It would probably take me the whole hour to give Dr. Quinn an adequate introduction, but in short, he is really a remarkable individual and leader in the field of global health whose work has impacted countless lives. He is founding director of the Johns Hopkins Center for Global Health and a professor in the Johns Hopkins School of Medicine, School of Public Health, and School of Nursing. He's also truly a personal inspiration for me as well, and many of the students who have had the opportunity to learn from and work with him. And he's contributed tremendously to the success of the Global Health Leaders Conference. So Dr. Quinn, we'd like to give you the warmest possible welcome to our 2024 program. I'll go ahead and turn things over to you.
Great. Thank you very much. And it is a pleasure to meet all of you virtually. This is a fantastic course that you're all signed up to be a part of. I'm looking at the number of people that have signed in for today's session, over 500. Really impressive. And I want to welcome everyone as well. I'm going to go ahead and dive right into my talk, which is very personal, as to how I got started in this field, how the field has evolved over the years, and I hope to end up with some recommendations for everyone. It's going to expand much more in the subsequent lectures that you'll be getting. But this should serve as an introduction as to what is global health, how does people get into it, what are the pluses and minuses, and how things have evolved over the many years. So let me get started. Let's get started. How does one get involved in global health? And probably my first message to you all is mentorship. I didn't know exactly where my career was going to go when I was in high school. I loved biology, and I sort of knew that I wanted to go into medicine, but I was still uncertain. But it was in my undergraduate years, and I went to Notre Dame. I met this professor, George Craig, and I put him up first because he was my advisor, my mentor, as I went through my early years of education. And he got me going in malaria. We're not going to go into the biology of malaria in any detail, but malaria is still the #1 killer in the tropics of children. And I know all of you have heard about it. There's all different types of parasites that cause malaria. They're in the Plasmodium genus, and they go through a life cycle that is over usually a 2 to 3 day life cycle, and it causes fever and anemia, and eventually, if it's not treated, it can result in death, mostly in children. Adults over the years develop immunity. They still develop illness, but it's really the children that suffer the major consequences, and of course, tourists to tropical areas. So I did my master's degree with him. I went into medical school, and I continued studying malaria while in medical school and while I started my infectious disease fellowship. Now, I had left my first mentor, obviously, as you will, but I then met my second mentor, and that was King K. Holmes. And I spent 2 years working with King, and I continued to work with King all the way through over 4 decades. So he's my lifelong mentor. And when I met with him, he said, pleased to know you're working on malaria, but that's not my area of expertise. He was more interested in sexually transmitted diseases, but was interested in international health and working overseas. And he had quite an influence on my educational development, I will say. And I switched while I was working with him to another organism. So I went from Plasmodium, that causes malaria, over to another bacterium called Chlamydia trachomatis. Chlamydia is the leading bacterial cause of sexually transmitted diseases. And here is its life cycle. And again, we're not going to go into the science of these particular infectious agents. I just wanted you to see it goes through another cycle, much like what malaria goes through. It's actually a 48-hour cycle. It's an intracellular bacterium that infects columnar epithelium and causes urethritis and cervicitis. These are infections, inflammatory changes of the genital tract. And it can be treated with antibiotics quite easily. And I got quite involved in developing diagnostic assays and treatment of this. So I was trying to blend my career into diagnostics, laboratory experimentation, and clinical care. None of this has taken me overseas or has really gotten me into global health. It was really a little bit later, after I finished all my training in 1981, and to many of you on this, listening in, this is uh, long time history, but all before you were all born. But in 1981, we get this magazine. It's a scientific one that's produced by the Centers for Disease Control called the Morbidity and Mortality Weekly Report. And it still comes out weekly, and it tells us in the field of public health and infectious diseases and chronic diseases, what are the most pressing public health issues? Well, on June 5th, we saw this interesting article about a new opportunistic infection. And that's an infection that takes advantage of a individual whose immune system has been weakened. That's why we call it opportunistic. Um, and it was called pneumocystis carinii pneumonia. It's actually a fungal infection that causes very severe pneumonia. And it killed these 5 young, sexually active homosexual men. So it only affected gay men in the beginning. Then the next month, another issue comes out, and it shows that this is expanding among homosexual men in New York and in California. And it was an alert that there's a new disease out. It's affecting gay men. And we had no idea at the time how severe, how bad was this infection going to be? And where did it come from? Where was it going? And the analogy I'm going to suggest to all of you is that you've just lived through something quite similar, and that was COVID, because that came out in December of 2019, just a few years ago. And by 2020, it had expanded throughout the entire US. Of course, that was hitting any individual. This was at the beginning only gay men, and it was invariably fatal, 100% fatality to any of the gay men that got infected. So we clearly were in the beginning of really a massive epidemic in the US in those first few years. Little did we know, and it's how I got into global health, that this was happening in other countries. We just didn't have the surveillance or the sentinel signs that we do today. that we jumped on COVID as soon as it appeared and we saw it was global. We didn't know that. At the time, we just thought this was a domestic infection affecting only gay men. But within a year, and this is all the MMWR again, that same CDC report, you can see if you look at the dates, July 9th, 1982, we're seeing these infections and this cancer that we call Kaposi sarcoma occurring in Haitians that were living in the US. We're seeing it among hemophiliacs, people who are receive blood transfusions, people that are pregnant and give it to their infants, and female sex partners of bisexual men. So if you added over this 1 year period, all these epidemiologic signs, you would come up with this is a blood-borne disease that is sexually transmitted. But we still, a year to 2 years after the first cases, we still didn't know what caused it. Whereas again, your analogy is COVID. We all knew what caused it. SARS-CoV-2 is the name of the virus that causes COVID. But here, we didn't know what was causing it. So the hunt was on, and anyone in the field like me of infectious diseases just went to town on this. And the first place I went was my first opportunity to go overseas, was to go to Port-au-Prince, Haiti, because of that report that showed there were gay men and bisexual men, Haitians, that had come from Haiti and were in New York and were being diagnosed with the disease. So we wanted to find out what's going on in Haiti. There'd been no reports as to what was happening there. So I flew down. That's a young version of me. Yeah, I had dark hair back then. And this was my boss at the time. His name's Richard Krause. He also turned out to be a mentor to me as well. He was replaced by a name many of you all have heard of, and that's Tony Fauci. He became my new boss. But this was in the last years of Dick Krause, serving as director of the National Institute of Allergy and Infectious Diseases. He has since passed away, and the rest is history that Tony Fauci took his place. But we went down there and we investigated this disease. This is a photograph as I walked through their wards. You can see that the ward was just swamped with people. And the disease, each of these people were affected by what we called AIDS, acquired immunodeficiency syndrome. We collected blood and started to look for what was causing the disease, but we found it was heterosexually transmitted as well as homosexually transmitted. So still a sexually transmitted disease, but being transmitted men to women and men to men. And so we pursued some investigations on this. We still didn't know what was causing it. We're into year 3 of this epidemic. But what we did find out was that some of these Haitians had been in a country called Zaire on equatorial Africa. Now, Zaire is now called the Democratic Republic of Congo. It changes names. But we flew from Haiti to Kinshasa. This is all the beginning of my international experience, trying to find out what's causing this disease. And these are the colleagues that I traveled with, again, a younger version of me. I set up the laboratory, and the others were epidemiologists, and they worked with me as clinicians. And we went and did ward rounds in Mamiemo Hospital, a 2,000-bed hospital. Not quite as crowded, but we were finding lots of the children infected with whatever this disease was. So we collected blood from the children, from the adults, and we sent it to the Pasteur Institute to try and find out what was causing this disease. while they were working with our blood supply, my colleague and I, Peter Piot, and the others on this list, wrote a manuscript on it describing AIDS as it evolved in a heterosexual population. And I have to tell you, fair warning, that when we first wrote this report up, we sent it to the New England Journal of Medicine, our top tier scientific journal, and they basically rejected it because they said, no, 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 this is a gay disease. This only transmits among gay individuals. And here we were saying, no, 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 this being transmitted among heterosexuals. So there was a big debate that was evolving in 1983, 84 as to whether this could be heterosexually transmitted. All of our data and other people's data from Africa clearly showed it could. Well, while this paper was coming out, turns out the Pasteur Institute had identified a retrovirus from our blood and the blood of people affected in Europe and in the United States. And they called it LAV, lymphadenopathy associated virus, but it turned out to be HIV, a virus that I'm sure all of you are familiar with and is the major cause of AIDS. And that stands for human immunodeficiency virus. Notice it's human. It's not saying gay or heterosexual, it's a human immunodeficiency virus, HIV. The other message I'm going to add, besides the mentorship, is collaboration. As you saw, I've always been working with teams, and you will find you will go much further when you get a team. It can just be one other collaborator, or it can be multiple collaborators. And this was the team that showed how this disease was evolving in Africa. We called it Projet Sida. That's just French for Project AIDS. Right, our Zairean colleagues were the heads of it. And we had Europeans. This is Peter Piot, the younger version of me, and all my other colleagues. Jonathan Mann is over here. He was one of our first CDC directors of the project. So very exciting time. Lots of great people that we worked with. I miss them all to this day. But we really did try to put together how this disease was being transmitted and what a threat it was to Africa and other countries of the world. And I'm just going to pull this little paragraph out of a paper that we wrote in Science. This is called AIDS in Africa, an Epidemiologic Paradigm. And I'm just going to read this because it's very important. This is 1986, so we're now 5 years after the first cases. This disease is transmitted predominantly by heterosexual activity, parental exposure to blood transfusions, and unsterilized needles, and perinatally from infected mothers to their newborns. And it will continue to spread rapidly throughout all of Africa. Prevention and control of HIV should be an immediate public health priority for all African countries. Well, sadly to say, this sort of fell on deaf ears. And this is what an epidemiologic curve looks like. Sorry, just for purposes of the screen here, this is 1992. We're at about 5% prevalence, and this is the spread of the virus all the way up to 45% infection rates going in one country that we worked with in Swaziland. So you can see the massive epidemic that took place. And we had no treatment during these years. it was really prevention by education. And that was really the sad part of this disease. Now, this is another photograph I took in Uganda. This is in Kampala. And all these individuals are infected with HIV. I had their permission to take their photograph. They are waiting to go into the AIDS clinic, but unfortunately, there was no treatment. Treatment was going through an evolution in the United States, and it was in 1996 that we began to actually be able to come up with very highly active antiretroviral therapy. But in the meantime, while we're treating people in the United States and Europe, the rich countries of the world, people in the poor countries of the world are suffering a terrible fate from this disease. This is a child that on your left screen was dying from AIDS. This is three children sitting on a freshly dug grave of their parents who both died from AIDS. Two of these children already have HIV infection, and AIDS orphans became a major health problem throughout all of Africa. So by year 2000, 2 decades into this epidemic, developmental gains of 3 decades had been totally reversed. The economic situation for these countries had declined by 10 to 40% by massive mortality. Health systems were in complete chaos. There was political and instability and insecurity concerns, increasing number of orphans, as I pointed out, and immense humanitarian concerns. And finally, what really raised the specter of the inequities going on was access to treatment. So the rich countries had now treatment by year 2000, but the poor countries didn't. And this it was appalling, to be perfectly honest. Part of the reason was that these drugs were brand new, they were expensive, and you had to take like 20 pills a day. It was horrible, even in the rich countries. And most people didn't think the poor countries would be able to take all these pills and all the side effects and be monitored for them. But over time, that pill burden actually dwindled down to 3 pills, then 2 pills a day, and now eventually 1 pill a day. So that couldn't be used as an excuse anymore. And so the United Nations, the World Health Organization, got together and in 2001, and this is actually before 9/11, the United Nations met and actually put together a declaration in which all countries signed on that they were committed to fighting HIV/AIDS. And you can see that with funding, a lot of things are more possible to buy the drugs in those rich countries and get them to the poor countries, and then eventually to make them in the low and middle income countries. This just gives you an idea of how it evolved. From 96 is like $300,000 towards AIDS relief. By 2001, that photograph, it was $1.4 billion, and then eventually grew up to $16 billion, and now it's $20 billion. We really need $30 billion to keep this up, but you can see it's leveled off, and we'll have to see what the future holds, and we're dependent upon our Congress and other countries' contributions as to whether we can attain these goals to treating everyone. So where are we now? And you can see up at the top the current data, but I prefer to show you the burden of infection. And it's color shaded. And the darker the red, the heavier the burden. And that's what's shown here in prevalence. That means 1 out of 10 or 1 out of 5 people living in that country are infected with HIV. We still see over 600,000 deaths a year. In terms of new infections, anywhere from 1 million to 1.5 million new infections still occurring every year. But treatment is making a difference. You can see from year 2000, that turning point, as we talked about. This in the bar graph are the number of people being treated with antiretroviral drugs. Now, remember, there's 39 million people living with HIV, and you can see we've gotten it up to pretty close to 30 million under treatment. But that means 9 million still are not treated. What this curve is mortality. This is the number of AIDS-related deaths. And it was escalating up until we reached about 2005, 2006, as treatment started to reach more and more people. And as it reaches more people, mortality declines. So let me just summarize. There was one program called PEPFAR. PEPFAR stands for the President's Emergency Plan for AIDS Relief. This happened under President Bush, but it was a bipartisan declaration, and the funding was every 5 years. There was enough funding to get treatment out. And this is just, you all have access to these slides. This gives you an idea that we have spent, just from the US, $110 billion since the beginning of PEPFAR, which was 2003. We've saved more than 25 million people, supported treatment for 20 million people. It's been the largest commitment by any nation to address a single disease, much more than COVID or malaria or any of the other diseases. So it truly is phenomenal. You can see how many people have been tested, how many babies have been prevented from getting infected, how much training has been supported. And again, the US is the single largest donor. This is taxpayer money going to try and deal with this scourge of a disease that has afflicted us now for over 45 years. So why am I focused on AIDS? It turns out AIDS is what brought the world's attention to global diseases, global pandemics. And this is just a copy of the cover page of Science, one of our best scientific journals, and also to the lay press, Time Magazine, Newsweek, all talking about the evolution of global health. You know, in the past, way back in the earlier years of the 20th century, we talked about tropical medicine. When I was doing my original malaria training, that was tropical diseases, tropical medicine. No one ever called it global health. And then that morphed into another terminology we call international health. And that's where you deal with diseases in other countries, right? So it's going to the poorer countries and helping with endemic diseases. So like malaria would be one of those problems. HIV/AIDS would, but HIV/AIDS was also a global problem. It affected Europe. It affected the United States, Latin America, Asia. It was global. And that is really the origins of our field of what we call global health. And you're going to hear a lot more, but I will tell you, back in the 1980s, no one used this term. The term has truly morphed over over those decades. So what is global health? How do we define it? And this is just one attempt. It keeps changing and evolving. And you'll see, I'll touch upon some of the other aspects of what we call global health. But let's, for purposes of this whole course, global health's an area of study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Okay, I don't want to keep repeating the term global, but it's worldwide and it's equity and how we address that. Now, it emphasizes transnational health issues, not one country, not just LMIC, but all countries. It looks at the determinants of health and the solutions to those health problems. It's also multidisciplinary, or you can say interdisciplinary. So it brings economists working with scientific people, working with clinicians, nurses, working with engineers to solve problems. So it's not just public health. Public health does look at population health across the world, but it's embracing other disciplines as we address global health. So it embraces public health, but we'll bring in engineering public health. We'll bring in medicine and clinicians and so forth. Now, global health in terms of health brings on many different challenges. This is just a few. These are the top causes of morbidity and mortality: infectious diseases, cancer, diabetes, heart disease, stroke. There are multiple studies. This is just to give you an idea how these things change. So we can actually say, what's the leading cause of death in the world? It's ischemic heart disease. 12% of people will die of a heart attack. 10% will die of strokes. 7% of respiratory infections, and so forth down that line. But there's another way of defining this, and you're going to hear more about this, and it's called DALYs, or disability adjusted life years lost. And when we do that listing, things change. So now lower respiratory infections or pneumonia actually goes to the top, causes more people to be ill during their lifespan than the other diseases, diarrheal diseases, mental illness or depression, and then of course ischemic heart disease, HIV/AIDS, and so forth. So if you are going to put funding into improving health, sometimes you're going to look at DALYs more than you are as to what's the leading cause of death globally. Now, in different countries, that will change. So you have to look at that. And it keeps evolving. I love showing this graphic because in 2004, if we would do a ranking of DALYs, like I just showed you, you can see the ranking, 1 up to 19 causes of disability adjusted life years lost. In terms of the future, 2030, you can see all those have changed. So now we are actually seeing that unipolar depressive disorders or mental illness is actually becoming the leading cause of disability adjusted life years lost. Look at road accidents, cerebrovascular disease, and so forth. You can see AIDS has dropped all the way down to number 9. So there's different ways of doing these calculations now and into the future. Why am I showing this? Because economists look at this, and economists are part of global health. You need funding to address the pressing global health issues of the world. So now, what is driving all these diseases and how do we address them? So this is just a quick look at some of the major problems. So number one is poverty. And you can see 1.2 billion people live on less than $1 a day. 1 in 6 are chronically hungry due to lack of funding and support. Population keeps getting bigger. Since I made this slide, it's now over 7 billion. But we have 400,000 to half a billion being added, million, half a million being added each day, and we're living longer. So the aging pyramid is changing. You only need to turn on your television or listen to the radio or read a newspaper that politics on the global scene are causing millions of displaced people and impoverishment and humanitarian needs. And you're going to hear about that coming up in the future presentation. And then there's environment. So much attention now being focused on the environment, and global warming is number one in terms of that. But there are other issues. There's pollution, there's famine, there's water shortage, food shortage, other types of issues that one has to focus on when you look at the environment. Just some photos to drive home some of these thoughts. Poverty, inequality, how some people live in impoverished, terrible conditions, and how that leads to disease. And then you have crowding and the overpopulation in some urban centers, and urbanization has taken over, and the movement of livestock into the urban center, leading to the spread of diseases. And we only need to look at the bird market and think about avian flu, the next major threat after COVID. And then there's transportation. People move around our world constantly. There's the old saying is be a virus and see the world, because a virus starting in Asia can be in Alaska or North America or South America, anywhere within 24 hours. So our ability to maintain and restrict the flow of people has changed dramatically over these years. And then, of course, all of you get educated about the environment and how that has even morphed into a new field, planetary science. So there's lots of different determinants of human disease. There's these underlying drivers, ecological drivers, proximate causes, and you can see again some of the limiters that I put in here. We do try to mediate some of this through culture, behavior, technology, philanthropy, governance, and wealth. How effective those are results in how severe the diseases impact different populations. So what we call the health effects. So you can use this as a driving force of global health or global disease, if you will. Now, Lancet's one of our other leading clinical medical journals. This one's from 2009. So we're talking over a decade ago. And even then, we said climate change is the biggest global health threat to the 21st century. Do you think people are paying attention to this or not? Are we modifying the factors that lead to climate change and global warming? I'll let you folks answer that. But if you use temperature as a guide to some of this, and these are different measurements, they all seem to be pretty consistent, that you can see this is in centigrade changes since 1980. You can see it has been steadily increasing, so that within the last 2 years, we've had the hottest recorded period of temperatures in our that's ever been recorded for the world globally. Excuse me. And what's the net effect of that? It's forest fires. You hear about this all the time, and there's ways of monitoring that. Temperature changes throughout the world. This is looking at increases in US heat-related deaths in high emission for the future. And this is doing some projections, but you can see that the risk as temperatures go up in terms of daily temperatures, so does mortality as related to heat-related deaths. So this is not benign. We have to be taking this far more seriously. 1 billion people are out working in these environments where the global temperature's risen more than 2.5 degrees centigrade. And so this is a major issue, and it's affecting all of the continents of the world. Now, I study infectious diseases. We started talking about AIDS as that evolution. We brought in COVID, but I borrowed this particular graphic from Dr. Anthony Fauci. This was in 2015. We could update it, but it would get too crowded. But these are all evolving, emerging particular diseases. And we don't have time, obviously, to go through them all. Throughout this course, you will hear more and more about them. I've talked about HIV/AIDS. I'll say a little bit more about COVID. But these are all threats to humanity, and they're increasing because of planetary changes, global warming in the environment. Now, I have often given talks about the comparison between HIV/AIDS and COVID. And this just gives you an idea of the mortality that both diseases gave. This is the quilts that represented the individuals that had died. They were dedicated to the early years of the AIDS epidemic. Each of these are the deaths due to COVID. Over 1 million people in our country died as a result of COVID, and the numbers continue. It is not gone from our landscape, nor is HIV/AIDS. So we have to be dealing with that all the time. This just gives you an idea. Up to January of 2024, we now have had a recent uptick in the last few months, but it gives you an idea of the magnitude of COVID that you folks have lived through and why there was so much attention to it. Fortunately, we have a vaccine. We talk about boosters and vaccination. Unfortunately for HIV/AIDS, we still don't have a vaccine, but we have treatment, very effective treatment. But you don't get cured by treatment. So we still have a problem with HIV/AIDS, but this is COVID. So we're talking 7 million people globally dying of this disease. That still pales in comparison to HIV/AIDS, which is over 40 million fatalities, but over 40 years. This is 7 million within just 2 years. So you can see there are similarities and differences. But the magnitude of both diseases is still striking. The beauty for COVID is that we were able to come up with a vaccine that did prevent more fatalities. Didn't really prevent infection, as many of you know, but it did prevent fatalities. So is that what we have to deal with? In my field, there's always a new infection to deal with. And I just thought in closing, I would show you a few. This is monkeypox, which we now call Mpox. We've dropped the word monkey because it's really a misnomer, but we left the M. So it looks like vaccinia or smallpox, but it's not, but it's related to that virus. And in fact, the smallpox vaccine can actually help prevent the spread of this disease. Is this something to be worried about? And the answer is absolutely. Just this year, 4,500 cases were reported in central sub-Saharan Africa. Why is that a concern? Well, remember, that's where HIV/AIDS really took off as a pandemic. So diseases like this can also spread because people travel. And in fact, it became a global pandemic 2 years ago. In 2022, we had over 87,000 cases. And look, this is where they were, the size of the circle represents the size of the epidemic that's occurring. And you can see the US was particularly hit hard with this disease. Here's the US in 2022, just 2 years ago, and you can see we had quite an epidemic with this particular disease. Sexually transmitted, close, intimate contact. But through public health measures, attention to it, vaccination, we were able to limit this disease. It still is there, but more under control because of the steps that are taking to limit a disease. This is my last slide, and then we can do some Q&A if folks are interested. This is, in closing, I wanted to put a few of this. These are just my recommendations as all of you interested in this field might consider. And the number one is go after your passions, just pursue them. If you're excited about biology, about public health and global health and medicine or chemistry, it doesn't matter. If it's engineering, that's fine. Architecture, all of these things all play into global health. So pursue your passions. As you're doing that, get advice from people in that field. So identify some mentors. It's a two-way street. They have to be willing to give the time, but you need to seek them out. Don't expect them to reach out to you. You need to be proactive in pursuit of identifying who you would like to have as an advisor. Take advantage of opportunities when they arise, and they will arise. Without a doubt. They did for me, they do for everyone that I interface with. And you just have to, rise to the occasion and pursue it. Be open-minded. Learn as much as you can through experience. If you get an opportunity to go and be active in a particular area, do it. Even if it's just shadowing. Try and experience as much as you can. Listen and inquire. Ask lots of questions. You may not be able to answer them all, but that just means that's an unanswered area that might need your input, your excitement. I mentioned along the way that collaboration was the way to go. Work with your peers, colleagues, and other experts outside your field. That is the way to really pursue that. And have a focus on equity. Remember, I said global health's all about equity, fairness, equal opportunity for treatment, for diagnosis, for clinical care in all aspects of health. And last, hey, enjoy this. You've all signed up for this course. Have fun, learn as much as you can, apply it to your daily activities if you can. If not, just really enjoy the whole educational process. And I think you'll find it very satisfying in the end. So let me close there. I'm going to close down my slides. I hope you've enjoyed part of this lecture at least. And again, thank you for signing up. Many thanks to Siam and his colleagues for getting this organized, and I hope you enjoy the rest of the course. Thanks.
Thank you so much, Dr. Quinn. That was really an exceptional presentation. And some really valuable advice that I hope everyone takes to heart and follows. It'll serve you very well throughout your career and educational journey. So as Dr. Quinn mentioned, we do have some time for questions. If you have a question, please kindly turn on your camera if you can, raise your hand, and then I will call on you. We unfortunately probably won't be able to get to everyone, but we'll try and get to as many as we can. Please just let us know your name, your grade, and where you're from. I first see Karthik. And I'll click the button to ask to unmute you. There we go.
Karthik.
Hi, Dr. Quinn. Good afternoon. Are you able to hear me?
Yes, I can hear you.
Okay, thank you so much for your time. I just had one quick question. So you had shown us a graph earlier in your presentation regarding the cause of death change from previous time to 2030.
Mm-hmm.
And due to those changes, will the practices that prevent those deaths and fatalities increase in need and popularity? Like, for example, like the depression, will like psychological practices increase in need in 2030?
Oh, most definitely. The responses to those changes, obviously, you need to be putting more energies. The economist is where I was putting that energy. They're going to need to put more financing into mental health over the years. We don't really see that happening, and that's a big mistake. We really need to be much more proactive. You're the generation that has to influence people to do that. You may not be the agents of change right now, but as you age, you will be those agents of change. And I hope you will, be cognizant that you can make the difference and you can influence through the electoral process and everything else. And if you're successful, then those dynamics will change. It's like HIV/AIDS. It's gone down. Why has it gone down? It's gone down because of treatment. The earlier we get people in treatment, the less sick they are. So they don't cause a disability-adjusted life years lost. So those preventive measures are very important. When we see these trends and projections, that means we need to act now to try and prevent those from getting worse. Hope that answers your question.
Yeah, thank you so much, Dr.
You
Quinn.
bet.
Thank you. Next, I see Princess. There you go. You should be able to unmute now. We can't hear you for some reason. We can come back to you, or you can send your question in the chat. In the meantime, I can go to Subhan. Sorry about mispronunciations, by the way.
Hello, can you hear me?
I can. Go to it.
Hello, I'm Shubham. I'm from New Jersey, going to 11th grade now. I have two quick questions for you.
Mhm.
My first question was, the way you started talking about AIDS and HIV at the start of your presentation. I worked at a ART center over the summer last year,
Great.
and one thing that I saw was they had to deal with stigma and like the people's process, which was heavily surrounded. So like at your time, like when you were working with this, what was one way like you had to deal with this and like stuff you had to talk about?
Thank you for bringing up stigma is the most important aspect of that disease. And in the beginning, as I pointed out, people were pariahs. I mean, if you were here, you were infected with a virus and you're dying, and people they made you lepers. I mean, it was awful. So how did we deal with that? Education, behavior change. Did we always succeed? Absolutely not. But we did try education. And now that we have treatment, people can lead an absolutely normal life. We can actually prevent transmission through what is called PrEP, pre-exposure prophylaxis. which you were probably heard about in those treatment centers. So now it's like diabetes. Well, you don't have a lot of stigma with diabetes. You have to take a shot of insulin or you take a pill. Well, HIV is the same. So it has more and more been destigmatized as a result. But is it gone? No. And I can tell you in Africa, still terrible stigma with just being homosexually active. It just is not accepted. And those are cultural norms that need to evolve and need to change. The only way you can do that is behavioral education, and it has to be constant.
Thank
Hope
you.
that helps.
And my second quick question was, as someone who's definitely been in this field for a long time, I'm also trying to like enter this field in the future. So what would you say in like the best way when you were starting off, like finding those mentors, those connections? What was the best way like to reach out and like find those people for you?
Two bits of advice. One, broaden your education to all aspects. As you just heard, some things are behavioral. And then I didn't have much of that kind of education. I mean, really, you're at a young age, keep it wide and broaden your educational process. But if there's a particular area you like and you seek a mentor, as you talk to people, don't be shy. Just reach out to them and say, I really admire what you do. Would you mind advising me from time to time? That's all you got to do. Just open the door. Have a little bit of an elevator speech, be modest, but also tell them, I'm really fascinated by what you do. Can I seek your advice?
Hmm.
And then you'll see where it goes. Some adults, older people, some are very good at mentoring, others are not. Don't be disappointed if you run into one who really doesn't want anything to do with it. You have to find one that you can work with. So it's trial and error along the way.
Thank you so much for your
You bet.
advice.
You bet.
Thank you. Princess sent her question in the chat. I'll just read it aloud. She says, my name
Yeah.
is Princess. I'm a rising senior from Maryland. How do you think the relationship between poverty and health access has evolved since your earlier research on HIV? And what measures do you think are the most effective in breaking that cycle of poverty and poor health in low-income areas?
Yeah, boy, do we have an hour for that question? That really is one of the most important questions that I get asked, and it's not easy in 30 seconds to give you a good answer. And so I apologize for that, and maybe we could email each other or something along those lines, because I know you have another lecture coming up now. But I would say the best way we had an impact was through the global, what we call the Global Fund, where multiple countries made donations, and then it was parsed out depending on the need of the country. PEPFAR was bilateral. That's US to our partner countries. But the Global Fund was more multilateral. And I think having both, having these donations go and having them target the need the most is what made the biggest difference. Sorry, I can't go on longer because CM told me you still have another lecture coming up.
Thank you, Dr. Quinn. If you'd like, our next lecture starts in about 45 minutes. Completely up to you if you'd like to take a couple more questions or if we should wrap things up.
How about one more? One or two? Yeah.
Sure. We'll take next is Salma. You can go ahead and unmute.
Hello, Dr. Quinn. Thank you so much for your amazing presentation. So I'm Salma. I'm from East Tennessee. I'm a rising freshman into college. And then my question was, which disease or project that you analyzed influenced your career and mission within the field most?
That's a great question. And I don't know that I can give you a single answer. I told you I started with malaria, right? And I would say my experiences working in the laboratory with my first mentor probably influenced me the most as to how to work in a lab and how to deal with a human disease from a lab perspective. It's a unique way of going about it. And then my second mentor got me going with the chlamydia and in general, sexually transmitted infections. And that actually formed the basis for how I could deal with AIDS. AIDS was a sexually transmitted disease. And the malaria part might have gotten me focused on laboratory, but it was really the clinical aspects of sexually transmitted diseases that really got me going in the clinical aspect of AIDS. So I would say it was dovetailed, the two, and that's why I put in that last slide, be open to opportunities, take advantage of chances when they appear. I mean, I morphed. I could have stayed all in malaria, and a lot of people do. It's still a major scourge for young infants, but I got excited about the other diseases, and so the two kind of complemented one another. So I hope that helps.
Thank you so much, Dr. Quinn. And for those of you who still have questions, feel free to discuss your questions with each other in the GHLC Discord. Sorry, we don't have the time to get to them all today. But thank you so much again, Dr. Quinn, for the really exceptional session today, and students for your questions and attention. We appreciate you attending, and our next session will be today in about 45 minutes. Please join the Zoom link again. It's from Dr. Paul Spiegel, the director of the Center for Humanitarian Health at Johns Hopkins. So we'll see you back in about 45 minutes.
Great. Thanks so much, Sam. And thank you, everyone, for signing in.
Thank you, everyone. I'll go ahead and end the meeting now. Bye.
Bye.